Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you very much, everyone, for joining, and special thanks to Professor Omar Aboumarzouk for joining, for his interest and for his time in delivering us this. This is gonna be a series of lectures. And just as a background, this started as an initiative towards mentorship led by the Sudanese Doctor Association, doctors in Qatar, Sudan. For male, it will be starting as a pilot for the Khartoum Medical Student Association as they approach us, asking for collaboration between the association and our association. So the things started to and fro. One of the domains was mentorship. Initially started, the thoughts was about clinical. Now it's starting as research mentorship, and then we'll see how things go. Uh, it's going to be also attended by a good number of other people. It's mainly directed for junior residents or junior staff, medical students, junior residents, and interns. So, without taking much of your time, it gives me a great pleasure to present our speaker today, Professor Omar Abu Marzouk. He's a distinguished urological surgeon with 7 practice years and uh, just let me with the with an expertise in open laparoscopic and robotic surgery in both benign and malignant urological diseases. Trained in the UK, he earned his master's degree in advanced surgical critical care, followed by a PhD in urothelial cancer, and completed a senior fellowship in endourology and upper urinary tract surgery at the prestigious Bristol Urological Institute. He's currently an honorary senior clinical lecturer at the University of Glasgow and an adjunct associate professor at Weill Cornell, Qatar. He's actively involved in teaching and PhD examinations, and clinically he's pioneered several firsts in the region robotic and laparoscopic procedures in Qatar, Scotland, and the Middle East. As a researcher, he was a leading researcher with over 200 peer-reviewed publications, 10 Cochrane reviews, and more than 75 international presentations, alongside serving as a senior editor of Blandy's Urology. And he has an H index of 45. At Medhamad Medical Corporation, where he is currently working, he established the surgical research section and now leads the artificial intelligence unit, driving the cutting edge research and global collaboration. We are very proud to have Professor Omar with us, as his career exemplifies his excellence in surgery, education, and research, making him a true leader in the field. So thank you very much, Prof. Omar, for joining us again, and it's a real pleasure to have you with us on board. And we're looking forward and eager to have your lecture. Thank you very much. Please, the stage is yours, Prof. Omar.
جزاك الله خير. بارك الله في جهودكم إن شاء الله. هو طبعا من الصدقات الجارية هي استجواب العلم and passing it on to the next generation.
يضربك والله يضربك ضربة.
Could everybody mute their mics? Inshallah. Ashhadu an la ilaha illallah, ashhadu Muhammadan abduhu wa rasuluh. Inshallah, we start. So this is the first of, inshallah, multiple series to try to teach research and try to help you. I wanted it more hands-on. So I'll go through the slides quickly, and then we could have some question and answer and see some topics as examples. But the key point about research is to start. A lot of students and residents and fellows, they tend to struggle بالبداية إنه they don't know where to start. You start, just pick a topic, even if it's been done before, and then ask the question, what do I do next? When I first started doing research, all my peers were doing case reports. And they were getting publications in case reports. And I remember Professor Rick Nelson. He was one of the prominent colorectal surgeons. At one stage, he's ranked in the top 10 colorectal surgeons worldwide. And he's also one of the very high respected Cochrane editors. He said, everybody's going to do case reports, but if you do a systematic review and meta-analysis, a Cochrane style one, you'll learn how to do all the other researchers. And I remember it took me about maybe a year and a half to conduct one. And it took me a very long time. But I picked a topic that was very simple. يعني ما في غير 2 or 3 systematic reviews on that topic, and I did a meta-analysis on it. And that was the start. And I understood from it how to critique a paper, how to write a paper, how to evaluate bias, how to do very basic statistics, and all these other things. And alhamdulillah, it led to multiple publications and presentations and so on. And through that, I was able to get my master's degree and PhD. So it started from the beginning. You just start one step at a time. It'll start slow. And soon, inshallah, it'll pick up. And right now, if I was to write a systematic review, it'll take me 2 weeks. And we've gone from a year and a half to 2 weeks. But yeah, okay. So I am older than most of you. So it does take. It's taken 15 years to reach here, but that's what happens with time, inshallah. So we'll give you a quick overview. We'll give you a quick overview of different types of researches that are available for medical practice. What you have to understand is what's difference between clinical research and basic science research is massive. The concepts are the same, but the way we do them and conduct them is slightly different. And I'll explain as we go along, inshallah. Now, I have no conflict of interest to note. Objectives is just to understand an overview of research in the clinical setting. So for doctors, nurses, physiotherapists, and so on. There's different types of researchers. You might have heard multiple phrases. You might have heard multiple ways of them being described and categorized and so on. But this is the general gist. They're all called observational studies or experimental studies. Those are the two main broad sections. And I expect 90% of you should be doing observational studies. Maybe those with more experience could start doing experimental studies, or if they have someone more senior who understands research a little bit more, they could do experimental. I expect most students, this is the easiest way to conduct them. Most students and residents could conduct systematic reviews and meta-analyses quite easily as well. So if you don't have observational studies to do, then at least you could be working on systematic reviews. Observational studies, very simple. It's the simplest type. It's everything that you observe. And we're just looking at what our clinical practice is. So a clinical audit comes into this category as well. I remember one of the simplest and most easiest ways that we did clinical audits as residents, we were required every 4 months to conduct one, is thromboprophylaxis in surgical patients. Are we abiding by the protocols of the local department? And over one day, we take all the patients that had surgery over the week, see if they were prescribed and given thromboprophylaxis appropriately, and then measured it against the protocol. The protocol says that everybody should, based on certain indications, and then we calculate. I remember the first time it was 80 something percent were receiving it, so that means there was a good 15 to 20% of patients that didn't receive it. So we wrote an email to the department saying that there's a certain number of patients that are not receiving thromboprophylaxis. We informed them. This is where it's important in an audit. And then a month later, we repeated the audit and found it to be over 95%, which was the minimum required in the department. And that was a successful audit. Simple. It took 2 days to do. While you're doing the ward round, you could gather the data and then analyze it over half an hour, and then just send an email out and then redo it again in a month. And that's an audit. It won't get a publication, but it goes on your CV as you conducted an audit. And this is a type of observational study. So observational studies are very characterized by duration of time. You could do it over one time only, so like cross-sectional studies or surveys. You could send out an email or send out a post, or you yourself could go and interview various candidates, grab all the information, and you're done. You have your raw data right there. And then you have extended period of time, such as case controls, cohort studies, longitudinal studies, and so on, where you set a time date. You want to look in the past 5 years, what our clinical practice was doing in 1, 2, 3, or I'm starting a new clinical practice. I want to see what happens in 5 years with my outcomes. Those are the very simplistic types. All of you have seen them, and when you read papers, they're all based around these three types of, or two types of observational study. Okay, direction of time depending on if you're going to do it today, right now, survey, asseria. That's it. You're testing. So, for example, in COVID, we did a survey of the effects of COVID on the stress levels of doctors, junior doctors, residents, and we sent it one email out with a automated questionnaire through the websites that do these questionnaires, and we had about 15 questions, and then we would get back the results. We sent the email out over one day, and we gave them 2 weeks to fill it out. It came back, and it showed that the stress levels was over 75, 80% in physicians who were actively managing patients during the COVID period. Then we wrote a paper, and it got published. Simple as that. And if you're looking backwards in time, it's called a case control study. So if you, for example, go onto a ward and say, well, we've started a new drug, and this drug has been used now for 2 years, and we want to know the effects of it. Or we've done a new surgery, and we want to know the results of this surgery. Is it successful? What is the complication rate, and so on. So you say, okay, I'm going to go back to 2 years. We started it 2 years ago. We'll go back 2 years, or we'll go back 1 year, and we'll collect all the data, and we'll analyze the raw data that we come up. That's called case control, or in other words, what you would call retrospective. So there'll be a lot of these terminologies that are going back and forth, but when you say case control, you relatively mean retrospective, but you could also have a prospective case control, and we'll explain that later on. A cohort study, or case series, small cohort studies, is what we would call a prospective studies. And so, as you can see, there's different terminologies that interchange. You are doing a new procedure today. You collect the data. That's a prospective study. And you're going for the next 2 years, you want to see what's going on. So it's slightly different to this. This is going back. This is going forward. Again, cross-sectionals right now, case controls in the past, also termed prospective, retrospective, and cohort. It looks into the future. What are you going to be doing? Prospective. What will happen to whatever it is that you're looking at? So most people that I've come across use only these terminologies. I'm going to do a survey. I'm going to do a retrospective study. I'm going to do a prospective study. And then when it comes to these, they get lost. There's like, okay, what's a case control study? ما انت بتعرف a retrospective study. It is a case control study. And this simplifies the terminology. Okay? And the question you'll be asking, is from a survey, what's happening? What's going on? What's your opinion? From a case control retrospective study, what happened? What were the results? And prospective, again, what will happen? What do I expect to happen? And what should be happening? A case series, okay, or if it's one case or two cases, case report. A case series is if you have a group of patients, cohort patients, that had similar illnesses or similar treatment modalities, or have taken the same drug, and you want to see what's happened with them. And this is the difference between basic science research and clinical research. Most clinical researchers, specifically observational study, some people will term it that you're hunting for a result. You're not hunting for a result. You're looking overall what your practice has been doing. Sometimes we find out, actually, I've discovered that my practice has yielded 1, 2, 3. This will be interesting to write a paper around. And that's where a hypothesis comes into play. Whereas basic science research, university research, you start with that question and you try to answer it. And that's the key difference. The reason why we're doing that is we have a broad way of looking at things from managing patients. Our aim is not to answer a question. Our aim is to manage the patients. Once we manage the patients, and we have a group of them or a case series, then we look broadly at what happened as we were managing these patients. And again, we go back into cohort, case control, retrospective, prospective, okay? This is the easiest type of a study that you could do, because if you've done it already, you could go retrospectively. If you're going to start doing it, you could do it prospectively. So case series could go both ways. You just need a group of patients that have similar diagnosis, similar treatment, similar conditions, and so on. Advantages: it's very easy to write up. It could provide you useful information. The larger the study, the larger the amount of the more amount of patients you have is also critical. So the more amount of patients, the more precise your results would be and more profound. Disadvantages is it's full of bias. I mean, if you, for example, have a case series where 5 consultants treated patients, they might have done different diagnostics, different treatment, just tweaked it a little bit. These are all types of biases. Or you might not have the full patient information, so you might have gaps in your information. Yeah, you'll have different types of biases, and that's what disadvantages a case series. And you should generate eventually a hypothesis from the results, but it's not conclusive because it's full of biases. A case control study, as we said, is retrospective in nature by definition, and you're basically looking at what we've done in the past, what variables, what risk factors affected this disease, what are the results of the surgery, what are the results of the medication that we've given this patient, and it's something that you could measure. There's 2 types of studies. There's case group, contains the disease, and control group that does not contain the disease. Characteristics, always controlled. So when you do a case control study, you're comparing, for example, a disease group to a non-disease group, and that's how you control it. It's always retrospective, so all of you know what a randomized controlled trial is. This is essentially the reversal of it. You're looking backwards in time rather than you're doing it as you're conducting it. And again, you need to have a time period for this. You can't just go haphazardly. So if you're going to have a disease group of patients over the previous 2 years, you need to include the same undiseased patients over the last 2 years, for example, and so on and so forth. And this is essentially what it looks like. So you start your study, you have a group of patients with the disease, a group of patients without the disease, or a group of patients taking medication, a group of patients not taking medication, who have not taken medication, a group of patients who had, for example, surgery A, based to a different group of patients who had surgery B. And then you find what the results are. Complication, no complication, success, unsuccessful, and so on. So to give you a real life example, when we first started out in Hamad, the breast surgeons came to me about breast abscesses. There were 3 senior consultants who treated each patient, who 3 of them had different ideas of how to treat breast abscesses. One would incise and drain, one would percutaneously drain, one would treat conservatively. So we had 3 groups rather than just the 2. And the standard, there was no standard. Across the world, these 3 were established modalities. So what we did is we went back 5 years in time. We took all 3 categories. The disease was all present in all of them. So we were looking at treatment rather than disease presence. We're looking at treatment outcomes. So we looked at the patients that had incision and drainage. What was the outcome? Recurrence of abscess, treatment of abscess, or complications such as scar tissue or secondary complications. Same thing for the percutaneous drainage, and same thing for the conservative management. And what we found in our cohort of patients, our group of patients, was that incision and drainage had the highest success rate, but it also had the highest complication rate, i.e. scar tissue. Whereas conservative management with just antibiotics had the least number of success for treating the abscess, but it had the highest recurrence of the abscess, or the highest secondary requirement of secondary procedure. And it was obvious that incision and drainage, though it did have more scar tissue, it was the best option because the patient then was cured of this infection and doesn't necessarily have to have it again. Case controls, they're quick and easy. They don't cost anything. You could do this at your own time. It'll just cost your time. This is good for investigators or doctors who want to write a proposal for more complex, more time-consuming study. So this is the benchmark, if you will, for a bigger study, for a randomized study, especially for those who deal with medication. And this is easy because anybody who wants to tick the box of having research. I mean, not everybody has the predilection of doing research. Some people just not interested. But as you go through your career, especially if you're going to go abroad or especially if you're going to go into a university hospital, research is one of the mandates. So if you want to tick that box so you have those points, you do a quick case control study. So you could have that in your CV that you've done research and you understand the basic principles of it. Disadvantages, again, bias. Again, most patients, the largest number of patients that you could have reduces the bias or errors. But the issue with this is that no one has 10,000s of patients. Usually they're in the numbers of hundreds, and that's because of the time limit, and that's because of the manpower that you require for various reasons. And they go on, it exists on records. I mean, the problem that, for example, we had in one of the hospitals is that everything was still paper. So you have to go through the paper. I'm not sure how it is in Sudan, but I'm pretty sure it's still paper-wise. And Hamad, everything is electronic, but it's difficult to grab all the information because it's written. Everything is typed. Unless it's specifically using phrases, the search engine won't necessarily find them. And it's very time consuming. And you might not have pre-existing evidence to know how to do that. And again, what is your control going to be? So I gave you an example of 3 treatment modalities. So there was per se no real control because all 3 were variations of treatment. That in itself could be considered a control. But the easiest way to look at something that's controlled is a diabetic patient taking this diabetic medication, which is new, compared to the standard diabetic medication. That could be your control group. The main drawback is false associations between exposure and outcome. So your results might generate confounding results that you might assume this is vital. And then when other people do similar studies, they might not find the exact association that you found. So it is very dependent on practices and, in my opinion, where in the world you're doing this. Again, we go back to the third type, which is cross-sectional study. Again, this is very easy. I gave you an example of the COVID and stress levels in physicians. It is a type of epidemiological study. It's straightforward. It's the easiest to do. And if you're lucky to pick up a topic that would be quite relevant worldwide, then you could make a paper presentation out of it. There are different types of cross-sectional studies, but the general one is called cross-sectional, but it's also called survey, epidemiological. Some people call it prevalence studies. It's just analyzing data. You gather information from a period of time, as we explained. What is happening right now? Are doctors stressed from managing patients who are COVID positive? That was our question. A lot of people in the States and Western countries in the beginning of the turn of the century were HIV orientated. I don't know if you've heard the news that they give blood and then there was scandals where patients are getting HIV or any kind of viral infection from the blood components and so on. And so this could cause also stress. This could cause significant problems. Now, the advantages of cross-sectional studies is quick and is expensive. I mean, literally, it takes you just a few hours of your time. and it only gives you a snapshot. So when we looked at the stress levels of doctors during the COVID period, we didn't take into consideration other factors, such as the working time, such as do you have any other issues in your life? Were you pre-stressed before COVID, or is COVID the cause of your stress, and so on? So it can be misleading. It can somewhat say, our results say, okay, COVID caused physicians to be stressed, but it's just a snapshot during a 3-month period. So it might not necessarily have been COVID. It might have been that the doctor or the doctors we grouped together, all of them had a variation of night shift just the week before. And because they had night shift, they were super stressed. They answered as if they were stressed throughout the whole period. And that's what we mean by snapshot in time. And of course, people don't participate. Generally speaking, it's between 40% to 60% who participate. So you have 40 to 60% who probably don't. So it's not very representative. In our survey, I think we had more female doctors answer than males. Okay, what's the back? Again, as you can see, bias will always come up. This is the issue with all these observational studies, is there's going to be high risk of bias. And again, it depends on the individual you're asking. If you ask someone who just come out of a night shift, or if you ask someone who just had a complication, he's going to give you negative answers. If you ask someone who just came back from vacation, is very relaxed, he's going to give you positive answers, and so on. So it's full of individual biases. And that's the problem with these cross-sectional studies, surveys. But again, it is a type of research, and we take it on face value. It could be separating cause and effect. To go back to the example I keep giving, if he had a very difficult night shift, the cause is that he's had a very difficult night shift. The effect is he's going to give you negative answers on your survey. It's very simple. Now, we go into longitudinal studies or cohort studies, and what some of you would term, or what you probably hear more often, is prospective studies. Now, the issue with longitudinal studies is they could be prospective or retrospective without a control. So you're just going backwards in time, looking at one specific thing, a group of patients, what's the outcome? Oxford Dictionary of what the meaning of cohort is, because people confuse what the meaning of cohort is. Cohort simply means a group of people or a group of things. A group is what it means. So you could have a cohort of colleagues, a cohort of friends, a cohort of patients. That's what cohort means. So when we say a cohort study, we're a group of patients or a group of procedures, and so on. Medical studies, a cohort is an individual who shares a common experience. So a group of patients who've had ABC surgery or take ABC drug. And then we go into the terminologies. Again, this is important to understand the differences between retrospective and prospective. It's different to the first terminologies we've used, but they work synonymously. So though the study was started here, we're actually looking at those who are exposed and not exposed, or those who have surgery, or those who take a medication, and seeing what happened with the medication. Was it treated, not treated? Those who were exposed to specific, for example, blood transfusion, did they get disease from it, or did they not, and so on. And those who were not exposed, did they get it? This is the best type of example, is to look at smokers and non-smokers. So smokers, did they get any disease in 5-10 years? No, they did not get diseases. Non-smokers, did they get the same disease? You have to look for the same disease as the ones that are exposed to be able to compare it. Okay? Does that make sense? Now, prospective, you probably have a predilection for an already existing hypothesis. So you would expect that smokers in 10 to 15 years would develop lung disease. Okay? Whereas non-smokers would not develop lung disease. A very nice paper was published about the effects of smoking and COVID. So what they found was they looked at all the patients who, they started their study, and they looked at all the patients who had COVID, and all the patients who smoked, all the patients who smoked, and all the patients who didn't smoke, and determined and calculated who developed COVID, who did not develop COVID, and so on in each category. And they actually found that patients who smoked were less likely to die of COVID, rather than there was no difference between them attracting COVID. So the difference between the two groups, they would both get COVID at the same incidence, but those who smoked were less likely to die of COVID. This was during the peak of COVID period, okay? So that was very interesting. That was a type of prospective study that was run, I think it was in New York. And this is just a representation of everything we've just spoken to. It's very simplistic. You keep it simple, okay? You have today. If you're going to do something today, you want to do something right now and see what everybody's opinion is right now, you're doing a cross-sectional study. If you want to go back in time, historical. If you want to do what happened yesterday, the day before, a year ago, 2 years ago, you do a case control, i.e. retrospective study. If you want to go forward in time, you want to see what your treatment of a certain disease is and what the outcomes of the treatment is, then you're going forward, you're doing a cohort study or a type of longitudinal prospective study. And then we come into the second part. So we did observational, and now we're doing experimental. Experimental is something you're testing. It's not the standard. And I'm a urologist, so there's multiple examples of that. But the biggest one, and in fact, there's nearly 80 or 85 randomized control trials on this. Does tamsulosin increase the stone expulsion in ureteric stones? Everybody's looked into this. Everybody's done a randomized trial in it. It's very simplistic. It's drugs. You give one group tamsulosin, you give another group an analgesia, and so on. Until today, there's variations of there's no two randomized trials that actually give you a straightforward answer, but generally, that's where the evidence comes into play, is that you group them all together. So we experimented with the patient. We gave them a drug that was not licensed or not provided for that specific purpose. So tamsulosin is used for benign prostatic enlargements, to relax the prostate, to allow for easier urination. But in this case, because of the mechanism of action of tamsulosin, which is an alpha blocker, it relaxes smooth muscles in the prostate and around the bladder neck, i.e. the ureteric orifice. Therefore, by theory, you're allowing the stone expulsion, you're opening the passages for the stone to be expelled easier. There's theories behind it. So people postulated that if we give the patient tamsulosin, it should increase the chances of them passing the stone. So they're giving patients this drug that's not licensed for this specific purpose and finding the outcome. In this specific purpose, they actually found that tamsulosin increases the stone expulsion rate by 20% almost. And by doing this, you're reducing bias because you're giving a group of patients the medication, irregardless of those patients. And there'll be two groups of patients. Again, this is our control group. A group of patients that will be given tamsulosin, and another group of patients that will be given something else, either just a sham drug, vitamins, M&Ms, whatever, or analgesia, and then you compare the results of the two groups. Okay? This is what's called a clinical trial. Could be done on humans or animals. Usually, if you're going to give chemotherapy, if you're going to give one of these drugs that have a lot of side effects and so on, they're started off with animals before they're giving into human trials and seeing the safety. Now, there's different types of experimental or interventional studies. We say interventional because it could be, for example, when they first started treatment procedures, they were experimental because it's not been done before. You could control, i.e. you have a group of patients who are doing the control, doing the experiment, and a group of patients who are your standard who are not. You could do them in parallel or concurrent. And this is where randomization, you could randomize them. So which patient will have it, which patient will be controlled, which patient would be in the standard, in the interventional or experimental group. Or you could non-randomize them. You could just group them. First 10 patients will have A, and second 10 patients will have B. And then you have non-controlled, okay, just after each other. So, for example, sequentially, so the patient can act as their own control. So, for example, you want to see a patient who's hypertensive. If you give them a type of drug, will it reduce their blood pressure? You give it to them, for example, 3 months. If it works, fantastic. Then you could say, okay, let's stop it and give you a different type of drug and see if it works as well. If it doesn't work, then you've done a non-controlled study. In urology, for example, we do this subconsciously or inadvertently. We do this with patients with overactive bladders. So what do I mean by that? So when we have patients with overactive bladder, we do have a stepwise ladder of how we treat patients with medication. But what I tend to tell the patient is, I'm going to give you something called sulfonisin, which is which works in overactive bladders. And some patients get side effects, some patients don't. So I tell the patient, we're going to give you this for 3 months. If it works, fantastic, we'll carry it on. If it doesn't work, we'll try another medication. So that patient has acted as their control. A crossover study is that you'll have a group of patients who are taking drug A and another group of patients who are taking drug B. And then after a certain period of time, you cross them over. Group 1 will start taking B, Group 2 will start taking A. And you could also do something called historical. I've done this. This is very interesting. So I'm doing, for example, what we did looking at robotic patients. What were the outcomes? And then we compared them to laparoscopic patients historically. When we first started out robotics, we wanted to establish that robotics was a viable method of treatment. So we did about 50 patients robotically. And then previous to that, we were doing all of them laparoscopically. So then we looked at the laparoscopic results and compared them to the robotic results. So this is a controlled, historical type of study. Sorry, is that a question or is that a comment or is that just?
No, sorry, it was just a mic on, so we just put it on mute.
Anyway, yeah. Okay, so that's a historical type of controlled study. Okay, a lot of us who are doing new surgeries, or a lot of us that are doing new practices, can do this much easier. What's the difference between cohort study and randomized study? There is no intervention or new intervention or experimental intervention in cohort studies. You're looking at your own practice, what you've observed in your own practice. Whereas randomized studies is usually something new, or you're comparing two interventions, or you're comparing two types of procedures. One of them might be new, okay? And you're observing, yes, you're observing what's happened. It's all called observational, but you're observing in something that is not necessarily to be standard. So for example, I just gave, robotic surgery was not standard across the board. Now it's pretty much standard because the evidence has been established that robotic prostatectomy, for example, is superior to open prostatectomy, to laparoscopic prostatectomy. Randomized, again, this is the problem with randomization. One study, you can't establish complete change of practice from one randomized trial. So there has to be multiple studies that undergo this that have similar results. So reproducibility in your results. Randomization reduces bias. Remember, all the observational studies, the major detriment was bias. There's always bias. Randomization removes this because it takes the opinion, or it takes the physician's role away from which patient gets what. So then you equalize all the patients across the board under the assumption that all the patients are on the baseline equivalent. And they're all around the same age range. They're both men and women, or they're completely all men or completely all women. They all have the same disease and so on. Okay, and then you randomize them. You take the decision's preference out of it. Then you truly randomize. So there's minimal bias from that point of view. Blinding, if you've heard of the word. So blinding is not only do you take the choice of which patient gets what treatment, that's from randomization, but you also don't tell or don't inform certain group of people. So, for example, in medication is the easiest way. So, in medication, you blind the drug, you don't name it, and you just show the physician that this is drug A. And then the placebo will be drug B, for example, but you don't tell the patient this is the placebo. You say this is drug A, this is drug B. And then the researchers are aware which patient had which drug. So that's called blinding, single blinded. There's also double blinded, where also the physician and the patient are unaware, or certain participants in the research study. And of course, there's also triple blinding, and there's quadruple blinding if you want even the statistician not to be aware of anything, just blinded completely, which is very difficult to do. But anyway, so the research team are unaware, and only the biostatistician or statistician is aware of exactly which patient had what, and he produces the results at the end of the study. So those are the different types of blinding. Again, we've gone over controlled. So you could have an independent control group, or you could have a self-control group, depending on the study and what you're looking at. Trials with external controls. So you could have external controls. So you don't necessarily have to have the patients with you. So if you had a trial running on a certain type of cancer and treatment with chemotherapy, and you had group A was the treatment group, group B was the control group. You finished your results, you finished your study, you completed your study and research project, and you've established whatever it is result. And then you're going back and you're going to go and do another study on a different chemotherapy on the same type of cancer. Rather than looking at another control group or recruiting another control group, you could take that control group from the original study, their results, and compare your new chemotherapy results to that. Okay? Now we come up to systematic reviews and meta-analyses. Again, these are time-consuming, but they're worthwhile, because I'd probably say 75% of systematic reviews and meta-analyses get published. So that's why these are always attractive for medical students and residents. So as when I was a resident and a fellow, I think probably 75 to 90% of my publications were systematic reviews and meta-analyses. Once we had more established practices, then they became more observational and randomized studies. So it's a good way to start off your academic career. And they increase your H-index significantly, because the more publications, the more references you get from reviews. And I'll explain that why later on. Systematic review and meta-analyses. So the difference is, I think I have what is the difference? So the difference between, essentially, a meta-analysis is a quantitative review, where a systematic review purely without a meta-analysis is a qualitative review. So systematic review, you're looking at the literature, evaluating a certain question, and seeing what different people, different studies, different publications have come out with the results. So you're elaborating your hypothesis, or you're elaborating what you're looking for. Whereas a meta-analysis is more quantitative. You're looking at results. You're adding up. You're using statistical methods to come up with the result. So that's why a systematic review and meta-analysis is slightly higher or superior to systematic reviews on their own. Systematic reviews, I remember when I was starting off, there was no framework, but the framework has now been established. It's called PRISMA checklist, or PRISMA framework, which is a structure that feeds you how to do it. Nowadays, actually, there's AI applications and websites that you could go on and input your data, and it could do the systematic review for you and give you the results. And a little bit of a cheat here, you could also do, if you have results, you could also do statistics and meta-analyses using the AI modules such as ChatGPT, or specifically DeepSeek, if you're aware of these programs. I've explained what the difference is between the systematic review and meta-analyses. So meta-analysis is more quantitative and systematic review is more qualitative. And this is the hierarchy of evidence. So background and expert opinion is the lowest. I love in theater when one of my colleagues comes up and say, so-and-so doctor and so-and-so country, his opinion is 1, 2, 3. It's like, yeah, good for him. It's just an opinion. It's based on his experience on his limited 10,000 patients, but there's hundreds of thousands of patients and there's experiences otherwise. Case control studies or observational studies, cohort studies, and case series and reports and so on. Again, they're snapshots. They're not necessarily establishment of evidence. Now, randomized trial is higher than them, but again, this is what I meant by one randomized trial cannot change practice. You need multiple of them. And then you have different types of hierarchy of evidence-based and guideline synthesis, and a systematic review and meta-analyses are usually at the higher end. You could do a systematic review and meta-analyses of case control studies. I've done a systematic review and meta-analyses of case reports. So I remember when I was a very junior resident, I looked at, when I was in plastic surgery, I looked at the effects of leech therapy on different parts of the body when they were used. And we had something like 350 case reports. Some mentioned 1, some mentioned 2 patients, some mentioned 3 patients. That was our cutoff, 3 patients for a case report. And very few were case series. And then we conducted a complete systematic review, and we analyzed all the data collectively and came up with the result. And that was published and actually went into a book chapter for one of the guys who were doing a PhD in leech therapy. But again, you could do systematic review on almost anything. You could do a systematic review of surveys if you find similar surveys. But again, the higher the quality of the basic study, the higher your systematic review meta-analyses would be more cited and more profound its effect and results. So systematic review and meta-analyses of randomized controlled double-blind trials are probably the highest form of systematic reviews. And that's us. Any questions?
Well, thank you very much, Prof. Omar, for this very insightful presentation about research, its designs, and pros and cons of each of them. It's really inspiring, and I think it will be an eye-opener for almost all of us, including senior and junior colleagues. I think now the floor is open for discussion. Whoever wants to discuss, just please raise a hand so that you can be given the opportunity to participate. Thank you very much.
No questions? That's a
Any
first.
questions? Yes.
I mean, we have 114 people.
Assalamu alaikum.
وعليكم السلام ورحمة الله وبركاته.
Thank you, Dr. Omar, for the amazing presentation. So basically, I'm not a physician, but I'm a clinical dietitian. So I basically been here for like almost 3 months in Doha. I came from the UK. And I was thinking actually to start a study within my facility. I actually cover the Cuban hospital, if you guys heard of it, in Dukhan. And there's so much going on in here, and literally just all over the places. And this was very useful actually to make me feel like what exactly I should be starting with. So I don't really have any questions, but I was just wondering if I can just meet you. If you can just tell me where your office is, and just to discuss so many ideas that I have in mind, and where do I start, and how is it possible to start it in Hamad, and what do I have to do? Do I have to cooperate with others, physicians and nurses and whatsoever, or can I just run it myself, or what do I have to do?
Well, yeah, I could meet up. You could speak to the organizers, and they could connect you later on. Regarding, do you need to do it with others? You could do it independently. You could do it with others. You could do it in one center. You could do it in multiple centers. We did a study in urology with thulium. We started off in Hazem and Berik, and now it's extending from Hazem and Berik, Hamad, I think Hamad's involved, and Aisha Hospital. So you could start off small and then expand it depending on what it is that you're looking for. The advantages of doing it that way is you get more patients. Again, if you remember the beginning of the slides, the more patients you have, the more credible your results will be, the more likely it'll get published. I remember publishing a paper on a specific urological condition where we only had 25 patients, and it was difficult for me to get it published. And multiple times we'd submit. I remember I submitting it maybe 6 times to papers, and they wouldn't accept it. So then I added a systematic review and meta-analysis to it. So I did a systematic review of the literature, and then I collected all the data from their results, and then I added my data to it. So I called it systematic review and meta-analysis of AB and our experience. So I grouped all the literature in this, and we came up with over 2,000 patients at that time, and it got accepted from the first time in a paper. So the more number of patients you have, the more credible your results will be, the more likely it'll get published.
Well, thank you very much, Prof. Omar. So we have 2 questions on the chat. The first question is from Muhammad Ahmed. Can you elaborate more on the difference between systematic reviews and meta-analysis, especially when you mentioned qualitative versus quantitative? Can you provide examples?
Yeah. So don't get misinformed. They're the same thing. They're just different types. I'm just trying to make it simple for you. If I say I'm going to come and do a systematic review of the literature on, for example, robotic nephrectomy, I'm evaluating all the literature in a systematic method or a systematic way, so I capture as many papers as I can that will show me a specific result that I'm looking for. I'm not analyzing any data. I'm just looking at the literature. To give you an example of that is you could do a systematic review on the number of publications or the amount of publications that were published in the COVID period. And I think the BMJ did this one. And during the COVID period, I think it was something like 80,000 or 70,000 papers were published during the first 2 years of COVID, which is ridiculous. Everybody was publishing about it, okay? Everybody was publishing. All the editors were accepting. So that's a systematic review. Now, if you say, I want to do a systematic review of robotic nephrectomy and look at the results. So I'm looking at numbers now. I'm looking at number of patients, demographics of the patients, the outcome of the patients, the recurrence of the cancer if there is, positive margin rate, and so on, various variables and data. Okay? Every paper reports on these. And you're taking all these results and putting them together. This is called a meta-analysis. You could meta-analyze or group the analytics of all the papers, any type of paper. It could be randomized studies, it could be case controls, observational, whatever. So I have a publication where, for example, tamsulicine. I was the first to write a systematic review meta-analysis on tamsulicine's effect on ureteric stones. And I got it published. Now, what I did uniquely was I included an arm of all the randomized studies, an arm of all the observational studies or case control studies, and I grouped them together, and then I analyzed them individually. So I'm using numbers, I'm using statistics to come up with results. And then I write the results section and discussion and so on. So that's a meta-analysis, when you meta-analyze, when you group numbers together. Now, if you're just grouping narrative or just grouping different opinions, so you could have a systematic review of expert opinions. So this is everybody's opinion. There's no numbers, there's no variables. This is just opinion, or a narrative review type thing, where you're analyzing 10 doctors are saying 1, 2, 3, 5 experts are saying 1, 2, 3. Based on the overwhelming opinion, our conclusion is A treatment is better than B treatment. So that's a systematic review without a meta-analysis. Does that make sense? Is that more clear?
Assalamu alaikum. This is Dr.
So
Afaf.
just, yeah, Dr. Afaf, we have two people, if you can just take their questions and then we take yours.
Sure. Thank you.
Yeah. So Mus'ab you have a question, I guess?
Yeah, I have a question. First of all, thank you so much, Dr. Omar, for this fascinating and informative lecture, as well as for Sudanese doctors to organize like such series. So just as kind of a reflection on the study that you did in systematic review during your like neoplastic residency, and you had around 300 or more than case reports around a specific like topic. So there are any like recommended, criteria for how many study or how many like paper I need to include in the review to be like robust and sound, or everyone can choose like any number of papers, or I have to cover the whole papers that published in such areas?
There's a good
So,
publication by the BMJ again, I think it was, where they looked at systematic reviews and the robustness of their conclusions based on the number of studies. And they came up with that a minimum of 10 studies for meta-analyses, the results would be more credible. Okay, so your minimum to have a strong recommendation is 10, I would say.
okay.
However, it's not limited by numbers. So, for example, one of my first Cochrane reviews was the treatment of neomycin and physiomycin in constipation in children. Okay? So remember, I work for a colorectal surgeon, so it was all about constipation and bowels. So when we did the review, we only found 3 papers or randomized trials. Cochrane reviews, the difference between Cochrane reviews and other reviews, Cochrane reviews only looks at randomized control trials. So we only had 3 randomized control trials that looked at Cisoprim, I think it was, or it's a type of neophysin. Anyway, 3 that looked at it. And we wrote the whole Cochrane review based on this 3. Whereas if you look at the Tamsulicine review, there were over 80 randomized trials included. So both got published, both got highly cited, but this is you're limited. You're always limited by what's available. So if you have a topic that has 2 or 3 studies out there and there's no other topic, and you did a robust methodical systematic review, then so be it. Do it.
Yeah, thank you very much, Prof. Omar. So we have another question from Halima.
Okay, thank you for the outstanding session. I want to ask about if for the junior, for those who are conducting their first research, is it advisable to do it yourself on a systematic review or meta-analysis, or you have to join to an expert?
Or you have to join what? Sorry?
I mean, for the junior, for the first time that you're doing a systematic review or meta-analysis, is it recommended to do it alone or to join to an expert before?
Well, I did it alone. So when I first started, most of my papers were alone. The reason why I would involve my seniors was for ideas. So I would speak to different, more experienced people. What is the evidence out there? What could we do a systematic review on? And they'd give me an idea. I'd go look at the literature, see if it's doable or not. 9 out of 10 times, it's not. But when you get the 1 out of 10, then you're going to spend the next few months working on that and also looking at other ideas. I had a list. I remember as a resident, I had a list of all the topics I wanted to look at reviews, and I would click them one by one. When I start one, I'd carry on. And then once you write the paper and submit it, it's going to take about 2 months for the submission process to be accepted or edited or rejected, and you resubmit. While I was submitting one paper, I was starting another review because of my checklist. Now, if you don't know how to do any of this and you don't have the predilection to go and research how to do it, then you find someone who did. So in surgical research, one of the units I established when I was head was a systematic review and meta-analyses unit. And I think we published nearly 20 to 30 publications, systematic review meta-analyses, all conducted by students from Qatar University or residents at Hamad, and Weill Cornell, of course, students. And they all got published. So we did it as a group. The only issue with it as a group is that which student will be first author, second author, and so on. Yeah, high logistics. But the way we overcame that is that if you and a colleague, for example, want to do systematic review, you would do one topic, she would do or he would do another topic. He would be first author on his topic, you'd be first author on your topic, and then you cross over second authors for their respective studies, and you do it together. And it's always better to do systematic reviews, meta-analyses as a group. Because when you evaluate the evidence, and there's something called critiquing the paper or evaluating the evidence of the studies that are included, it's always good to have more than two people, ideally 2 or 3 people that critique an individual paper to see if there's any difference between their critiquing of the paper and then resolving it with discussions. So that's why we usually like groups. But if you, for example, have published multiple systematic reviews, meta-analyses, yeah, you could do one by yourself. Why not? And if you're interested, again,
Okay, thank you.
This is the point of these meetings, or this is the point of these lectures, an introductory meeting, is that anybody with an idea for a research project, I'm happy to come and supervise, and I'm happy to come and coach and do it. But we're also going to provide lectures, inshallah, in the future, when, if time allows, of how to conduct these things, how to write a paper. If anybody has, for example, already patient cohort and they don't know what to do with the patients, we can help them analyze the data and so on and so forth.
Well, yeah, thank you very much, Prof. Omar. And as I mentioned at the beginning, this is the first of a series of lectures aiming for mentorship program that is going to be launched soon. The collaboration between our association, the Sudanese Doctor Association in Qatar, and the Khartoum Medical Student Association. There will be like mentees that will be selected by the KMSA, and Dr. Omar has kindly agreed to mentor a certain number of them. So we'll see how things go. So this is just the beginning. We said we'll just do a kickoff so that we know what is going on. And just to have sort of an objective reflection, I'll be posting now on the chat. There is a link for an evaluation form that we kindly need your feedback about the session and any suggestions that we can consider in the coming topics and the coming sessions. Dr. Afaf, yeah, if you can give us your question, and then we have a couple of questions on the chat before we conclude the meeting. Dr. Afaf, please.
Thank you, Doctor. First, I would like to thank Dr. Prof. Omar for this insightful presentation and the Sudanese Doctors Association for the arrangement. My question is, in the era of AI, what advices can you give us to translate AI into clinical research? Thank you.
How we could translate AI into clinical research? A lot. AI is going to replace us all. There are websites that conduct systematic reviews for you. You could use various chat-based AI programs such as DeepSeek and ChatGPT to actually analyze all your data statistically, or do a meta-analysis for you. You provide all the tables and say, meta-analyze these and provide me the graphs. But what these AI tools don't do is evaluate the evidence exactly. So you know what a specific operation is. AI is only currently limited by what it searched while people are looking. So if AI has not come across that specific topic, it's not linked. ChatGPT, DeepSeek is not currently linked to Google search or Yahoo search or any kind of search engine. So if you go onto DeepSeek and say, when was your last update, or when are you updated to, DeepSeek is actually updated till I think mid 2024. ChatGPT is updated to I think April 2025. So they're not updated day by day. So unless they are linked to a search engine, there is a new, or I've discovered it newly, Perplexity. It's linked to, it links these chat AI programs to the internet, so it can make it more modern. So if you do search, if you do a search, it is more updated. But again, I wouldn't recommend using AI just yet. There's also Gemini, I agree. There's also Copilot. There's about 7 or 8 right now. But what I recommend is learn the basics, learn how to do it yourself, and then you could use these AI tools to assist you and make your life easier. Okay?
Well, thank you very much, Prof. Omar. So I think we have a few questions. The one question was about if there is no topic in the area, so what can we do? Or I think if there is no papers on a question being investigated, so what evidence do we next rely on? I believe it's just a new idea. So
yeah. So if it's a new idea, then your evidence will become the basis.
yes.
So that's easy. Let me give you an example. We did something called elastography for detecting a prostate cancer. It's using an ultrasound machine and measures the elasticity difference between prostate and prostate cancer, normal tissue and tough tissue. And I have a general rule. Before I start any research project, I need to do a systematic review. I want to see what the evidence out there is. So I did a systematic review, and I found that there was no papers written on elastography for prostate biopsies. But there was elastography for liver, elastography for various other diseases or organs. So I did a systematic review and wrote that there is a lack of evidence published on said topic. This is my results on said topic. Does that make sense? So when you have very lack of evidence out there on a specific topic, you become the novelty of it. So it increases your chances of it getting published because no one else is doing it. And you want people to know that actually I have excellent results in ABC because I'm using this new technique. One thing that we popularized when I was a resident was PDD, photodynamic diagnosis of ureteric cancers. PDD has been used in the bladder before us many times. In the ureter, it wasn't used. So we started using it, and we established basically the evidence that we could use oral PDD, because usually it's intravesicular. Inside the bladder, we instill the solution. So we established that we could use oral PDD, and it's just as diagnostic. And we established that it has high diagnostic accuracy for detecting cancer versus normal tissue. And we established the side effects, and we established everything. Since then, 3 other papers in 3 other centers across the world, one in China, Japan, and America, emulated what we did, and they did research projects on that. And now it's in guidelines. So now it's in guidelines that PDD is a way of using, is a way of diagnosing ureteric cancers. And that we didn't realize no one's done this. It was by chance, subhanAllah, by accident, let's say, that we realized that, okay, let's do it in the ureter to see what we find. Heck, it was just a question. Is that, can we do it in the ureter to see what we find if we find it? And one thing led to another. So yeah, if you find a topic that there's no evidence for, by all means, don't just drop it, pursue it. Where do you search systematic scientific papers? Sure, PubMed has 90 to 95% of all published data. That's what I use. I use exclusively PubMed, and to be honest with you, Google. But I use PubMed. And what I found in the last few years was PubMed has the majority of all the papers.
Yeah, so thank you very much. There was a question that I answered that if can include systematic reviews in a systematic review. I just replied yes, it is called systematic review of systematic reviews.
Yeah.
So yeah, I think what's the difference between systematic review and a scoping review? Dr. Omar, that's another question.
So again, it's in the wordage. Systematic review is a methodical way you put down a protocol of how you're going to search the literature with terms, phrases, timing. So someone asked earlier, can I cut my papers from 30 to 15? Well, what I did was I was looking at laparoscopic procedures. Laparoscopy started in the 1991, the first procedure. Since then, thousands of papers were written on laparoscopic procedures. But I wanted only the most recent. So I put in my methodology, I will only include those papers from 2015 till 2020. I'm not, or 2025. I'm not looking beyond that. So you put in your criteria that as long as you're able to justify, my justification for that was robotics started hitting really hard in 2015. Before that, it was on and off. Not many people were doing it. So I want this era. So I limited my papers from thousands to hundreds, for example. So this is a systematic way of looking at the literature and grouping papers that are similar. Okay, scoping review, you're just hunting. You're just Googling. You're just putting into and the first 10 that come out, you grab. So I wouldn't do scoping. Scoping is just to increase your knowledge. Scoping is just to increase your know-how or understanding of a specific topic rather than conducting a research systematic review.
Remember, just a question. They're asking if we can share the presentation with them.
I thought you did already.
No, because I didn't have the emails, but
Yeah,
I just wanted your permission before I put it on the chat.
Share away.
Okay, so I think I'll just share the presentation now.
But bear in mind, guys, don't rely on this presentation. This presentation was a synopsis, a very small aspect of each of these, just to give you an idea of what types of research are.
Well, I think this is yeah, I've shared the presentation. I think you have it now. For the guys in from Khartoum Medical Student Association, the KMSA, I can share the presentation with Iyad, and then he can share it with you guys. From other people, I'll just put my email here. If you for any further query, you can just approach me. So this is my email for further investigation, further communication. So I think we've been like 20 minutes past the time. Please do not forget to fill the evaluation form that I have posted earlier, and I'll just copy paste it again for you just to have it handy. So it's here. The end of this talk, I really would like to thank Prof. Omar for his time, for this very informative and comprehensive presentation. It's really, I think, an eye-opener, and it will be the first, as we mentioned, for a lecture of series that will follow. So, and I really thank you for our attendees for their time and for the participation and the enthusiasm that they have shown. Thank you very much, and we conclude our meeting. I'll just stop the recording, but I will leave the chat open for those who want to download the presentation and to fill the evaluation form. Thank you very much.